Thank you. Sir, shall we start, sir? Let others can join parallel.
Yeah. Let them join. Yeah.
Okay, thank you, sir. Lakshmi ma'am? Yes, ma'am, we can start formally, madam. Lakshmi ma'am?
So yes, am I audible, sir?
Yes, ma'am, you're audible. You can start formally, madam.
Okay, sir. A very good morning to one and all present here. And on behalf of Biomedical Department, Arupadivid Institute of Technology, I welcome you all for the webinar session on cellular growth factors as therapeutic targets for combination therapy in androgen independent prostate cancer. In this regard, I would kindly request Dr. M. Ravindran, Professor and Head, the Department of Biomedical Engineering, to present the welcome address.
Good morning, one and all present, and warm welcome to all the participants who are attending the wonderful talk today. And a special welcome to our today's speaker, Dr. A. Sumati. She's heading the Biomedical Sciences Department of Ramachandra University. And ma'am, thank you very much for accepting the invitation and giving a talk today. Since I know you are busy and you have made yourself free for some time for us, so it's really a privilege, and we are happy to have you today. And I hope this talk on cancer is going to be very much useful. We have some students who are working on cancer diagnostics also, who are working on photoacoustic agents. So I think they will also get some information on this cancer treatment and diagnosis. So it's going to be a wonderful session ahead. And I hope all the participants will have a thought-provoking session today. And over to you, ma'am. Please go ahead. Thank you.
Thank you, sir. Now I request Ms. Sandhya to give a brief introduction about our today's speaker, Dr. A. Sumati.
Yeah, ma'am. Dr. A. Sumati, Professor and Assistant Dean of Students, Department of Biomedical Science, Sri Ramachandra Institute of Higher Education and Research. She completed her bachelor's degree in BSc Biochemistry from Bharati Women's College, University of Madras, Diploma in Basic Biotechnology, and Master's in MSc Biochemistry from ALM PG Institute of Basic Medical Science, University of Madras, and done PhD on the topic entitled Biochemical and Pharmaceutical Studies in Patients with Diabetes, and she's qualified in state-level eligibility tests conducted by UGC in 1997. Speaking of her academic and research experience, she has 21 years of teaching experience, 15 years of research experience under DBT ICAR sponsor projects, examiner in UG and PG in various colleges and universities, member of Board of Studies in various colleges and universities, launched Biomedical Science in Time Training BITT at Biomedical Science, introduced workshops for biology school teachers at Biomedical Science. Speaking of her project guidance, she has guided 5 PhD projects, 10 MSc projects, 10 BSc projects, and 4 summer fellowship projects. Speaking of the publications, she has published 5 national and 8 international papers in well-reputed journals. She has received 3 Best Poster Awards and 3 Best Paper Awards. and she is life member in Indian Science Congress Association. She has completed 2 projects and resource person in many national and international conferences. It's a pleasure to have you for this webinar session, ma'am. Now may I request our resource person, Dr. A. Sumati, to please take the session forward. Thank you.
Thank you. Thank you, madam, for that warm welcome and introduction. Good morning, students. At the outset, I would like to thank the principal, Dr. Shanmuganathan, Arupade Video Institute of Technology, and Dr. M. Ravindran, Professor and Head, Department of Biomedical Engineering, for inviting me to deliver this talk. Thank you, the other 2 faculties who gave a warm welcome and introduction. Thank you. I would like to share my PPT. Is it seen?
Yes, ma'am, it's visible.
Yeah. Yes. So, students, so I will be talking about on this topic for another 45 minutes to 1 hour. So please bear with me. I have prepared my talk very simply for you to understand easily so that you can raise some questions. So that is what is very important. So understanding comes from, I strongly believe that the understanding comes from what you have understood. So you can ask me questions at the end of the session. Just make a note of what you want to know. I would be very happy to interact with you. So today my talk on the cellular growth factors as a therapeutic targets for combination therapy in androgen independent prostate cancer. Yeah. So as you all must have heard, today cancer is a big problem among the population, even not only in older population, but also in the younger population. So that could be due to many reasons, because we have changed our lifestyle entirely. We forgot to walk, we forgot to eat healthy food, and we forgot to relax. So there are a lot of reasons that I can list it out. So of many cancers, today we have, I have chosen the prostate cancer. Basically because recently we have come out with some kind of proposed mechanism, and one of my research scholars is also working on it. So it is really quite interesting, because the prostate cancer develops as the androgen dependent cancer. You know, the androgen, the hormones, the testosterone and dihydrotestosterone. So, but later on, after quite period of time, maybe after therapy is started, or even the castration is done, that is the removal of the testes, androgen in cancer. So it's really difficult to manage such an independent problem. We would like to let's discuss about the prevalence. So what is the prevalence among men in the world and in India, especially because we are here to have a concern on the Indian population. So basically before, the prevalence of prostate cancer was more in the Western countries, because their lifestyle and food types are different compared to us, because we have a very traditional kind of food. So based on that statistics, USA tops among was in prostate cancer among men. But later out the westernization lifestyle, that is to save the time and to have a tasty food, and all those factors has become more, we got addicted to those factors. Hence, it become prevalent now in India. It is also emerging very badly in India. And in India, among top 10 cancers, the prostate cancer also has been listed out. And especially in Delhi, it is about second commonly diagnosed prostate cancer. That is how the statistics says. Out of all the malignancies, 6.78% accounts for this prostate cancer. So the incident rate of prostate cancer is 9 to 10 in 1 lakh population. Probably seems to be less compared to the USA, but compared to other Asian country and Africa, so it is more. We have more. The incident rate in India is more. So this is the report very recently given by the Indian Council of Medical Research. So I think it's very alarming that the prostate cancer is one of the emerging cancer among the population. Like the most important factor, the common factor is aging. So it is advised that after 45 years, from the age of 45 years, it is suggested to have a regular checkup on the antigen, the PSA, prostatic antigen. So which gives forefront information about the elevation of this PSA is an indication of the pathogenesis of prostate cancer. So according to World Health Organization, through the GloboCan 2018 report, says that there are new cases found. So this is various cancers are shown in this bar diagram. So our interest for today is that the prostate cancer in men, it is about 7.1. So this is the up to 2018. I have a separate statistics for the 19 and 22. So for this, if you look into this, 7.1% of the population is got affected actually, and out of which, if you see, the death is quite high, actually 4.5%, of which 4.5% of the population is dead. So it's really pathetic. Could be due to the major cause of this death from the prostate cancer is the metastasis to the bone and lymph nodes of the cancer cells that ultimately resist the conventional androgen deprivation therapy. We shortly call it as ADT, androgen deprivation therapy. You remove the gland or the testis which is producing the androgen hormones, androgens. Okay, so finally, the medical outcome could be the treatment of any diseases, but when the disease is uncontrollable and causes resistance to the treatment, I think we need to say the situation is very alarming, and we need to look into some kind of new therapeutic strategies so that we can reduce the percentage of death. So as I told you, this androgen ablation therapy in the case of advanced prostate cancer is often successful. Okay, so it's very alarming that we have to look for the new combination therapy. So that is what the today's talk is going to be. And if you look into this fact, it shows that in 19 and 20, there is a new cases and also the death. Okay, so there is a quite significant number of death, and every 3 minutes and every 2.7 minutes in the current year. So the new cases are emerging. Okay, so that it is mandatory and need of the hour to go for looking the new strategies, treatment strategies. And before I start and go into the signaling pathways which causes this androgen independent prostate cancer, we need to know a basic kind of anatomy about the prostate gland, as well as the normal signal transduction in the prostate gland, and synthesis of androgens, as well as what is derangement in the signal transduction. So this is how the other few minutes are going to go. So the prostate gland is a very small one. It's a walnut-sized gland that you could see located between the penis and the bladder. Okay, so you could see a small green color ball-like structure. Okay, so it's very small, you could see, and the prostate cancer is formed here in the peripheral zone of the prostate gland. So the main function of this prostate gland is to produce the prostatic fluid and hormones, and they regulate the flow of urine as well. So these are the basic functions that a prostate gland perform. And what are the symptoms? So how do I suspect that a particular person develops, or they could be having, prone to get such kind of things? We have already studied that the poor diet and poor exercise and even genetic, the hereditary cause is also one of the things. So it is advisable that in the family, if anyone has such kind of a history of prostate cancer, it is advisable to go for a regular test. So the frequent urge to urinate, the person who is affected with this prostate cancer, they will have a sensation of urination at a frequent rate. And while urinating, they'll have, it could be a very painful process for them. Okay, it's a painful urination they feel, and they often get urinary tract infections. Okay, so these are all, and sometimes, of course, blood in the urine. So these are all some of the symptoms. So it is always not the symptoms in the men, but you can, if it often happens, I think we shouldn't ignore those kind of symptoms. Better to go to a doctor, and the respective medical tests are done on time, because anything that is being investigated and ruled out in the beginning will always have a better treatment options. So let us not ignore these kind of symptoms, suppose if we feel that. So as I have told you already, the hormones. So these are the main culprits. The hormones which are synthesized in the testes, as well as the adrenal gland. The adrenal gland is the one which is present on the kidney. So these are the two sources from where the hormones which are involved in the prostate cancer development is very important that we have to look into. So I would like to brief on some of the hormones, like what are the hormones that are involved in the pathogenesis of prostate cancer. Is that promoted into the dihydrotestosterone by the enzyme 5-alpha reductase. This is the main enzymes which converts this testosterone into dihydrotestosterone, and this dihydrotestosterone, that is DHT, is the most biologically active form than the testosterone. It doesn't mean that the testosterone is not active, but of course this is more active than the testosterone. So these DHT, after converting the testosterone to DHT, they bind to the androgen receptor which is present on the prostate tissue, and there is these receptors, the androgen receptors are nuclear receptor. So, and this nuclear receptor is a ligand dependent transcription factor. So once this hormone binds to the receptor, it forms a hormone ligand complex, which then will be translocated into the nucleus for further transcription activities. So the androgen secreted by the Leydig cells of the prostate cells, and which includes, as I told you, testosterone and dihydrotestosterone, which regulate the growth and development of the prostate gland and testes. And these androgen synthesis in a normal condition is being regulated by various hormones, because under normal metabolic conditions or under normal intracellular signaling conditions, there will be always metabolism is regulated by either the negative feedback loop or positive feedback loop. So because of these regulations only, any synthesis or catabolism is being regulated at a normal rate, and the homeostasis is maintained. Okay, so this homeostasis is a condition has to be maintained in the internal environment to keep a person hale and healthy under normal conditions. So this is very, very important. The synthesis of androgen is also one such thing has to be taken care of. And these are done by the luteinizing hormone releasing hormone, which is secreted by the hypothalamus. Okay. So the luteinizing hormone and the follicle stimulating hormone. So the luteinizing hormone secretion is completely dependent on this releasing hormone from the hypothalamus. So the hypothalamus controls the synthesis of or secretion of luteinizing hormone as well as the FSH, the follicle stimulating hormone by the anterior pituitary hormone. So these hormones collectively work together in the synthesis as well as the prevention, in the sense they regulate. Okay, so when you have extra synthesis, then after some time it has to be regulated. Apart from those two hormones and LH, RH, the prolactin is also plays a very important role because they stimulate the proliferation and differentiation of prostate cells along with the other three hormones which I have discussed in the previous slide. And finally, the corticotropic releasing hormone secretes the adenocorticotropic hormone. Okay, and this in turn produces the dehydroepiandrosterone. This dehydroepiandrosterone is capable of converted to testosterone and prostate, because these are the two things which could bind to the androgen receptor. So the adenocorticotropic hormone, which releases this dehydroepiandrosterone, is further converted into testosterone, and this testosterone can again be converted into DHT by the 5-alpha reductase, which we were discussing in the previous slides. So finally, if you look at the things, there are a lot of hormones which involves, right? So it's really a complex process, and that is why the problem of attending the development of androgen independent cancer becomes a very challenging one, because we need to address the issue in different angles, right? You can't only look in terms of ACTH or only in terms of prolactin, because they involve in proliferation and differentiation, but also the other hormones. So it's become a multitasking, and it's really a complex one. So this is a beautiful schematic representation which gives an idea about how this hormones regulate the androgen synthesis and the AR signaling, that is androgen receptor signaling. So here, if you look into this, whatever that we were discussing about the hormones, hormone releasing hormone, LH, RH, the LH, ACTH, all these, like this is the hypothalamus pituitary gonadal axis. This is the one. Okay, so they from the hypothalamus stimulates the secretion of the luteinizing hormone. Okay, so from the anterior pituitary. So this luteinizing hormone is from the anterior pituitary, the LH-RH from the hypothalamus. So once the luteinizing hormone is secreted from the anterior pituitary gland, which will take care of the testicular androgen production. The main role of this LH in production, that is, it synthesizes testosterone. Okay, and I was mentioning also that the anterior pituitary gland not only secreting the luteinizing hormone, but as well they have a adrenocorticotropic hormone, which in turn helps the kidney, where the adrenal gland is present, helps to secrete the androstenedione, that is dihydroepiandrosterone. So this is what is called. Okay, so once this androstenedione from the kidney and the testosterone from the testis is formed in the circulation, they enter the prostate cell. These, they are called free androgens. Okay, the androstenedione and testosterone, they are free androgens, and they are capable of entering into the prostate cell for further mechanisms. And then once it is enter the prostate cells, they converted into dihydrotestosterone, this one. by the same enzyme 5-alpha reductase. So this enzyme is very, very important, okay, because they are responsible for the conversion of the hormones finally into the DHT, because I told you this is the potent biological active form, can bind to the androgen receptor inside the cell. So this DHT that is formed binds to the androgen receptor. The AR is meant for androgen receptor, leading to the receptor phosphorylation. So this red color ball on the this hexagonal structure is the phosphorylation that has been taken place, and this is the heat shock protein. And once this phosphorylation is being carried out, this is being removed from the androgen receptor, and there is a dimerization occurs. The androgen receptor dimerization occurs during this phosphorylation. Once this is the eligibility criteria for the androgen receptor to move into the, to get translocated into the nucleus. Okay, so this is the androgen receptor complex, ligand complex. They just move into the, translocated into the nucleus, where it binds to androgen response element, okay, which is at the promoter region present on the DNA. And so it is just bind to this place, and they recruits that, because it attacks the target genes, and then they will be recruiting the co-regulatory proteins, as well as the transcription activation is started. So you could see the expression protein, and which is responsible for the cell proliferation, cell growth, and the PSA level. Okay, so this is the normal mechanism and how the hormones are being controlled, and how it is transcribed, and how this ratio of co-regulator and co-activators are taken care of by these elements. Because you could see that black color line, which is the negative loop. Okay, so when there is a sufficient amount of transcription genes are targeted, there will be a negative feedback loop. So these secretions of all these will be prevented for a quiet period of time, because this is what the exact mechanism is required by the body for the regulation of hormonal synthesis. Okay, but this kind of mechanism is being impaired during the prostate cancer. Impaired in the sense there won't be any control. Okay, so if you stop the enzyme, so you can use as one of the inhibitor to inhibit this enzyme, so that you can further stop the formation of DHT, so that there won't be a ligand to bind to this. But these cells, cancer cells, are very smart than us. They will find an alternative route to go and bind to the some other, they get activated, the androgen receptor get activated through some other pathways. And that is the reason for the development of androgen independent prostate cancer. That is what we are going to look into in the forthcoming slides. What are the factors that causes the androgen independent prostate cancer to develop, and so the metastasis further. So this is some of the factors that causes. In the beginning of my talk, I was mentioning about some of the risk factors. The first common risk factor, we wouldn't even thought that I might get, so, or he might got the prostate cancer, he's going to develop. So we never think about it. Okay, so aging is one of the common factor or the influencing factor in the prostate cancer formation. Along with this aging, there are other factors helps this aging, taking this aging as a adding advantage to for the pathogenesis of prostate cancer, especially the family history, the genetic. Suppose in your family, if anyone has affected with this prostate cancer, of course you need to have a pedigree analysis, then look for the opportunities or the potential cause or the percentage of occurrence that can be predicted through the genetic mapping or pedigree analysis and all those things. And the next factor could be the diet. Okay, consuming lot of lipid containing food. Okay, so there is a derangement has been study of lipid metabolism. Derangement in the lipid metabolism, like especially the cholesterol metabolism, has been studied in the pathogenesis of prostate cancer. And a particular race, particular community of people are getting this kind of racism is also common. So like in USA, they have a high prevalence. Okay, and of course there is any other hormonal therapy which you had taken for some other reasons might disturb the androgens, the concentration of androgens, that also may be a adding factor. And the chemicals, so we may not know the chemicals, of course, part of the diet nowadays, right? So we take colorful food from outside. We don't know what kind of chemical is present. And we take nowadays the food that with the vegetables, the fruits that we consume, we may not know. So all these are some of the factors, and we need to be really careful and overcoming all these factors influencing the formation of prostate cancer. So what are the current treatment methods available at present? Why are we in need of new therapeutic strategies is a big question mark, right? Of course, there is no less treatment is given by the doctors, and our scientists are continuously putting their effort in finding out new mechanism oriented research, which will have a new targeting therapy. But still, as I told you in the beginning, in general, the cancer cells are very smarter than man. So they find a loophole through many other intracellular signaling pathways, and they find a way to progress. So what is the current treatment therapy for the prostate dependent cancer? That is androgen dependent cancer. Of course, the first and foremost one, the active one that the physician or the oncologist follow is that androgen deprivation therapy. That is, you make the prostate gland or the system unavailable for androgens, because in the previous slides we discussed androgen is very essential to bind to the androgen receptor. So if you remove the ligand, there won't be a further activation of the androgen receptor. So one kind of treatment was thought that if you remove the ligand, that is what is the androgen deprivation therapy, which is short and called as ADT, which includes the surgical and chemical castration. So the androgen synthesizing gland can be removed. Okay, so that is what is the castration, the surgical removal or the chemical removal of the gland. And androgen inhibitors, you can use some inhibitors to prevent the binding of these androgens to the receptor, or orchiectomy, that is removal of testis itself to lower the testosterone levels. And the LH-RH analogs, because this is the prime factor from the hypothalamus, helps to release the luteinizing hormone, and then the luteinizing hormone along with the ACTH helps further. We have seen in the previous slides. So analogs can be, these analogs will reduce the androgen levels. And maximal androgen blockade or therapies of the androgen dependent prostate cancer. With the ADT, the androgen deprivation therapy, we normally think that, okay, if the prime factor is removed, all the problem will be sorted out. No, to our surprise, after this ADT, the DHT level, that is the dihydrotestosterone level, declines in the serum. Circulating level may be decreased by 90%, 95%, but not in the prostate cells, that is in the tissues. The level of androgens in the tissues has not been reduced to the significant level. So these androgen receptors, being very smart, make use of these tissue available testosterone and progress further. So this is the reason a major proportion of the cases show a disease relapse. So the relapse is always a problem. The relapse and then progress as a castration resistant prostate cancer. Most of the time, the castration resistant prostate cancer are synonymously mentioned as androgen independent prostate cancer. Okay, so in my talk, even further, I'll be using this and this alternatively. So, but both are the similar terms. So, how this androgen independent prostate cancer develops? See, initially, the recurrence of prostate cancer after this ADT, androgen deprivation therapy, is considered. Now, actually, I told you, no. So we thought, okay, the problem is sorted out by removing that. So now we'll not have any problem. Most of in the beginning, it is independent. It seems to be independent. I mean, seems to be a problem is solved. But after some time, the amount of androgen that is being left out in the tissues slowly increase, and they in turn activate the androgen receptor. And this is the smartness of the androgen receptor, which get activated at the lowest androgen concentration. Even a small amount of androgen that is being released from the tissue can be utilized for the AR activation. Okay, so the first strategy that the androgen receptor does is that they started utilizing, or they become oversensitized. Okay, they are so oversensed, so they can even survive, bind with the lowest amount of hormone that is available in the tissue. Hormones, the AR can interact very well with the other signaling pathways and causing the androgen independent prostate cancer through both genomic and non-genomic alterations. I will explain in the forthcoming slides what is this genomic and non-genomic pathways. Okay, so the genomic pathways is once through targeting the transcription genes. I mean, I told you to the AR and the ligand, the complex, translocated into the nucleus and binds to the androgen response element. I was just talking about this here, right? So this is genomic, but non-genomic is these AR and ligand complex will activate the growth factor pathway, epidermal growth factor pathway, that I'll come to that later. Okay, so that the AR activation with this small amount of hormone is also mediated by other parameters, the growth factors that helps the prostate cancer, and they just boom as androgen independent prostate cancer. Okay, so this is a beautiful diagram, will explain to us how and what are the factors that involves collectively in causing the development of castration resistant prostate cancer or androgen independent prostate cancer. So look at this. This there are it's numbered 1, 2, 3, 4, 5, 6, 7. The first factor is the intratumoral androgens. This is what I was talking about, the availability of the hormones inside the tissue. So they are so happy with a low amount of hormones, the binding of the androgen receptor is possible and forms a complex. So this is one of the factors which influences the development of CRPC. Okay, the second one, overexpression. Okay, to meet the need of the more transcription factor, the AR, the androgen receptor, is overexpressed. We must have studied, we must be having a basic knowledge in the endocrinology that the expression of the receptor is more even when the hormone concentration is less. That is what we call it as amplification. Okay, so they are very smart. The receptors are so smart to amplify. So this AR, the androgen receptor gets overexpressed. And the third factor is AR gets mutated. Okay, so this MUT is the mutated androgen receptor, which is something quite different from the normal AR. Their splicing mechanisms would differ because this AR mutated, mutated AR is more happy to bind to this. Form this CoA activators and repressors, and so that they can bind along with the phosphorylated wild type AR. The fourth one, as I was talking, there is always the co-activator and the co-repressor ratio has to be maintained in maintaining the androgen receptor synthesis. Okay, so this is also one of the reason gets impaired. This is also, this ratio is impaired. And the fifth one, as I was talking about, they act through epidermal growth factor. This is the non-genomic pathway. Okay, so these are all genomic pathways. Now the non-genomic pathway is that they come through the epidermal growth factor receptors. One of the main receptor that they use for the development of androgen independent prostate cancer is that the activation of EGFR, because this activation of EGFR, epidermal growth factor receptor, activates the PI3 kinase, which in turn activate the AKT. These two are the main pathway involves in most of the progression of the cancer through the non-genomic pathway. So, am I audible? Hello?
Yes, madam, you are audible, madam.
Yeah, thank you. So, this is one of the tumor suppressor gene. Okay, so in general, normally under normal circumstances, this P10 is a tumor suppressor gene which suppresses the conversion of PI3, conversion in the sense the activation of the PI3 and so the AKT as well. But under the AIPC, they are very smart enough to suppress this suppressor protein, deactivate this P10, and hence the PI3 AKT intrasignaling pathway can be expressed here and happily transcribed or translocated into the nucleus to transcribe the required proteins for cellular proliferation, metastasis, and also the PSA has been increased in the serum. So, because of this genomic and non-genomic activities, the anti-apoptotic pathway gets overexpressed. The BCL2 protein is overexpressed. So they develop the anti-apoptotic nature to the androgen independent prostate cells. Okay, so these are the factors which influences. As I told you, so the first this schematic representation gives an overall view of how this androgen dependent becomes androgen independent because of the ablation therapy or castration, and so this forms the AIPC, and these are the other contributing factors: intratumoral androgen synthesis and mutations. The mutations in the form of methylation of DNA, and as I told you, the AR is getting amplified, overexpressed through gene amplification, and there is a crosstalk. The crosstalk, the AR talks with PI3 and AKT. So this cross very in cancer signaling pathways. So because of this crosstalk only, our therapeutic development of therapeutic strategies become very, very difficult, because when you cut one signal, they can survive through another. So in the treatment of cancer cells, and so these are the factors which we can discuss one by one, because they have a very, very important role in the development and progression of the AIPC, and hence the death occurs. So the intratumoral, as I told you, it's a synthesis of the availability of the small hormone molecule inside the tissues. And during the androgen starvation, the cancer cells develop alternative mechanisms for the intratumoral androgen synthesis using adrenal androgens. Because the adrenal androgens is being synthesized by the ACTH, and the ACTH, that is adrenocorticotropic hormone, is secreted not only to maintain the level of testosterone, but also for the so many other metabolic pathways. So these adrenal androgens exploits the availability of ACTH, and so they can trigger the androgen receptor. Okay, and also in some of the studies have during the metastatic androgen independent prostate cancer. But we know the nature of isoenzymes, right? Isoenzymes, a single enzyme with different properties. They catalyze the same reactions, but they have a different properties like immunological and electrophoretic. So the measurement of these isoenzymes as a marker is really challenging unless you can measure the amount of isoenzymes that is present inside the tissue and helps in the conversion of binding of the androgens to androgen receptor is really difficult. So inhibition of the enzymes, the particular enzymes, the 5-alpha reductase, suppose if you inhibit that, the other isoenzymes of 5-alpha reductase can exhibit their role at that time, and so that the adrenal androgens can easily be converted into the dihydrotestosterone and then bind to the AR, the androgen receptor. So they are very capable of surviving. When you cut one enzymatic pathway, they can bloom with the formation of the or usage of the other isoenzymes of such kind of enzymes. So the second option, as I told you, the factor is the overexpression. They get overexpressed, right? But and also the mutations. See, normally I have not shown here this androgen receptor structure. They have a ligand binding domain. They have a N-terminal, C-terminal, and DNA binding domain. All these are present in the androgen receptor. So when it is overexpressed, also they just change their nature by mutating themselves. Even it could be point mutations. So that these kind of mutated AR is also expressed, and there is increase in the androgen receptor co-activators and to repressor ratio. So this leads to the high levels of genomic instability and chromosomal rearrangements, that is aberrations. Okay, so if you look into the in terms of therapeutic strategies, it's really difficult to understand at what level the treatment could be targeted. So that these mutations androgen receptor to the other non-steroidal ligands as well as anti-androgens. So that with these newly formed AR, okay, the AR is also, one is overexpressed, the other one is mutated, and the mutated AR is over smart enough to activate the non-genomic pathway, that is nothing but the tyrosine kinase pathway. Okay, so the another factor is overexpression and mutation. So that the third big problem is the crosstalk, right? So the crosstalk that happens between the other pathways. So the non-genomic pathway, as I told you, include the EGF pathway, which activates the epidermal growth factor, and then this androgen mediated upregulation of EGFR, and which in turn activate the MAP kinase pathway through PI3 and the ERK pathway as well. So as I told you, the PTEN is inactivated. It's a tumor suppressor protein which gets inactivated, so they are helpless, and so the PI3 and AKT pathway becomes very, very active, and they suppress the bad protein which is pro-apoptotic. But in this case, the suppression of this tumor suppressor gene will make this bad also inactive, and so that the BCL2 level is increased. So the BCL will further proliferate, helps in the proliferation and causes the metastasis. See here the androgen dependent signaling, there is androgen dependent cancer and this independent cancer. This is something which I was talking about, the genomic pathway. This is a non-genomic pathway. So this non-genomic pathway are capable of activating all these JAK-STAT and PI3 AKT and MAP kinase and ERK signaling. And so that what happens is, once this dependent signaling, where we have already studied this AR this complex binds onto the androgen response element, and which in turn gets in the form of phosphorylator. It can also be activated. It's a two-way process. Okay, so the genomic pathway can also activate the non-genomic pathway. So as I told you, the intratumoral androgen level, that small amount of hormone can help in activating the AR. So with this activation, they are smart enough to activate reversibly the intracellular signaling, the non-genomic pathways. So that is what is mentioned here. The non-genomic pathway as well as the genomic pathway both helps in the proliferation of cells, and so it develops a mechanism of anti-apoptosis by reducing the bad protein. Okay, because the PTEN is inactivated, so that we have no other way, because this is also found on another way. This also has the reversible. It is the forward as well as the backward possibilities through which it can anyway get activated. Okay, so we need to identify some strategies, and this treatment has to taken care of all these. It's really complex. It's really complex. So this is one of the examples that I have taken for the EGFR. So this ERB2 is one of the EGFR family, and you can see how smart these the cancer cell, by taking a different route. See, once this EGFR is activated, they activate the RAS, RAF, MEK and ERK through this SHC and GRAP protein. These are all some kind of immunoproteins and phosphoproteins. All these proteins are getting phosphorylated at their serine and threonine residues. So they all get activated. Once they all get activated, it increases the cell survival, migration and proliferation. This is one way. The other way, they can also activate the STAT by phosphorylating these two proteins, and so they could activate the androgen receptor overexpression, and further they can increase all this. The other possibility which I was talking about is that the PI3 AKT pathway, wherein this ligand binding to this EGFR can activate the PI3, which in turn activate the phosphatidylinositol phosphate 2 signaling molecules, which in turn converted, that is, it gets phosphorylated, and so the AKT. So once the PI3 kinase is activated, the AKT is also activated default. So, and finally they help the support to the cell survival migration. But these are the two proteins which helps us generally, but they have been suppressed by the tumor cells. Okay, so they see to that the anti-apoptotic proteins and the genes get suppressed so that they can easily grow and migrate and cause the metastasis. So these the red line shows the inhibition. Okay, the black shows the inducible pathway. Yeah. Okay. So this diagram shows us that what are the current therapeutic targets. So what we have discussed so far, genomic, non-genomic and hormonal ablation therapy, androgen ablation or a deprivation. Hypothalamus secretes the luteinizing hormone, releasing hormone. And here, this is one point where we can develop the antagonist and stop the secretion LHRH. This is one possibility. So the another possibility is that the conversion of the testosterone and androsterone which enters the prostate, and this prostate can be removed by the surgical castration, and no more the gland which could support these hormones. And the another possibility is inhibiting this enzyme, which is very, very important in the conversion of testosterone to dihydrotestosterone. So this is another possibility that is in practice. And the next possibility is that the dihydrotestosterone which enters the cell, right? So anti-androgen inhibitors and heat shock inhibitors, because the heat shock protein is very, very important, because on phosphorylation, it's a part of the AR. On phosphorylation only the HSD will be removed. So if you add this inhibitors as a treatment strategy, they will take care of not releasing this HSP. This is one possibility of treatment. Another possibility is that all these intracellular signaling has to be stopped so that the prostate cells, that is the AR, cannot communicate or do the crosstalk with this non-genomic pathways. But this is being in practice. But as I told you, if you stop this or inhibit this enzyme, the isoenzymes will come into role. So this is also, it's not very successful for epidemiological castration. Even if you remove this, then they will find some other alternative through the adrenal gland. So from where they can synthesize the androgen, and so that each treatment has its own defect. And somehow, after a period of time, they develop resistance towards a particular therapy, because no treatment will be done collectively. So normally the physician will go one step at a time, right? So, but for this kind of resistant or the independent development of prostate cancer, we feel that it has to be addressed at once at different point of time. As in a different therapeutic targets at different target levels. Both genomic as well as non-genomic pathways has to be collectively taken care of, so that not giving any chance to the cancer is what we have thought about it. And that is where the combination therapy plays an important role. So in this combination therapy, the usage of more than one compound, is practiced. So to address the interlinked complex pathway that is developed in the androgen independent prostate cancer, really make it very, very difficult to address the single targeted therapy. So in this androgen in advanced stages, the patients are normally given with chemotherapy. We go for chemotherapy, and which gives relief for shorter period of time. But after, as I told you, they develop a resistance towards a particular drug. One such drug that is being used is the daxitoxel. Is nowadays is used, and also they use in the beginning prostate cancer like bicaltamide and abiraterone. So these are the drugs also used. But after some period of time, they develop resistance towards that particular drug. So that is where the problem really becomes bones. So we need to develop a combination therapy to address these issues. And during that time, there is a debate arises whether to use these drugs at a higher concentration for a shorter period of time, or in a shorter doses for a longer period of time. So these kind of debates have could be answered only based on the research. We need to standardize certain dosage on a period basis, time bound basis. So what are the advantages? Okay, why this combination, how this combination therapy could be carried out? Of course, there is an advantage, which could, the combination therapy increases the efficiency of the drug at a lower dosage, because when we give large doses for a quite period of time, drug as well. Even if you take a 10 grams of drug which cures you faster, you cannot take it because the body is capable of absorbing the drug with particular concentration. So all the other drugs will get excreted over a period of time. It depends on the half-life of the period. Half-life of the drug. So we need to standardize a dosage which could increase the efficiency at its low dose. At the same time, it could simultaneously inhibit the multiple pathways. The ligand, that is in terms of drug, the drug as ligand is capable of binding to more than one receptors, okay, at the same time, so that we are not giving any time for the cancer cells to develop the resistance. So these combination in a different two forms. One is vertical blockade. The other one may not be a very successful one in resisting in the prevention of development of AIPC. The other one is horizontal blockade, wherein the multiple drug target different pathways simultaneously. This may be an effective one. Therefore, the inhibition of androgen receptor through mechanisms along with ligand manipulation might provide a therapeutic benefit. Okay. So the advantages, we need to look for the advantages as well as the disadvantages, of course. So advantages in the case of combinations therapy, or they will have a very reduced side effect. Okay, and increase the drug availability. Even the dose is less, it is sufficient to meet with the bioavailability, and less chances of development of drug resistance and increased drug absorption. So how this combination therapy could apply in the case of prostate cancer, and especially to prevent the development of androgen independent prostate cancer. You need to attack the or target the pathway, different pathway at the same time. So the combined inhibition of androgen receptor as well as PI3 and AKT pathway through the EGFR, epidermal growth factor, and we need to have a inhibition of cell cycle regulators and again AR pathways, combined inhibition AR with the different therapeutic drugs, and yeah, this is what is already mentioned here. So that the main, according to this combination therapy, the probable pathways that could be targeted, or you need to manipulate the AR mutation or overexpression, as well as you need to target the HSP inhibitors with target the HSP with the HSP inhibitors, and target the PI3 kinase and AKT signaling pathway. So when you do all these at the same time, hope the outcome in terms of preventing the AIPC. So what could be the future prospects in combination therapy? Suppose when we treat the treatment with the combination of drugs increase the survival rate. That is what we want, right? Because most of the time the prostate cancer people, they don't even realize that they are affected with even they can also survive with the prostate cancer for more than 10 years with some kind of therapy. It's not very, very dangerous like the other cancer, but still we cannot leave this androgen dependent cancer without giving much attention so that they become resistant. And the combination therapy provide a great prospect for future cancer treatment with reduced side effects, and also they reduce the chances of resistant developments in cancer cells. So this is one of the latest publications that we were thought about on this aspect, and I'm happy to share with you this. And I thank really the AVIT for giving me this opportunity. I would be happy to take some questions from students. Thank you one and all for your patient listening.
Yes, thank you, madam. Thank you so much for your various insights on prostate cancer. So in this regard, so I'd like to request students, if you have any questions, you can ask that.
Yeah.
Or you can just raise your hand. I'll allow you to talk. We have a question in chat box.
Where I can see the question.
It is there in the chat box, ma'am. Otherwise, I'll read it. How to reduce the chance of getting prone to cancer?
I'm just looking for the chat box.
Yeah.
Generally, okay. How to reduce the chance of getting into cancer? Am I right?
Yes, madam. How to
Am I
reduce
right?
the
Is that the
chance
question?
of? Yes, madam. Yes, madam. That is a question.
Actually, the first and foremost is if it is genetic, it's somehow unavoidable. Probably we can go for gene therapy, but I don't know how far it is being successful. So if it is based on gene, the cause is the hereditary, then it's mostly unavoidable. But early detection, like the breast cancer is one such thing, and as well as we saw the prostate cancer. So the regular checkup and early detection can always able to get your good health from all these available treatment strategies. And before I say this, I would also like to insist on take care of your habits, like diet, like your exposure to various environmental factors, like sleeping on time, eating timely food, eating good food, and don't stress yourself. And all these, previously our ancestors did not have this much or this many number of cancer cases the hospital has registered. All these because of the development of the various technical thing. Majorly, I would say our diet and lifestyle. So if you look into the literature, mostly 80% of the literature says that one of the main cause of formation of cancer is your environmental factors. So take care of all those things, and early detection is better, and you need to do regular checkup over a period of time, maybe after 40 years or 35 years itself, they say, because most of the women are not taking care of the checking up with their cervical cancer and breast cancer, and like in men it's prostate cancer. And our eating habits affect our stomach, so that the colon cancer, because one of my research area is colon cancer as well, where when I was searching for the literature, it's really it's amazing that most of the colon cancer is mainly due to the food habits. They say that highly fried foods and untimed food, no sleep, they say less sleep prone to cancer because it causes stress. Stress is the oxidatives are important source in causing the cancer. So as youngsters, you all have to be very careful with your food habits and the type of diet that you take, and have enough sleep habits.
Yes, ma'am.
Yes.
So
Any
thank
other
you. Thank you
question?
for your answer. So is there any other questions from the participant side?
But still, there are some in the chat box.
Yes, sir. Yes, sir. I'll read it, sir. And we have
Yeah, please.
questions actually. How we can control the hormonal secretion in order to reduce the cancer? Answer.
How to reduce the hormonal secretion in order to reduce the cancer?
Yes, ma'am.
Okay. See, the hormones secretes based on our response to situations. Okay, so control your emotions. And as I told you in the beginning, genetic outcome, or genetic background, we can't do anything to do with the genetic background. If the cause is due to the genetic background, we have to face it. Only one thing, early detection is possible, because you had a history of your family members had, so you can regularly check it, and there are good hand of cancer marker tests are available nowadays in the developed laboratories, so you can regularly check up that. And but otherwise we need to keep our mind, emotions under a controlled levels, because we have in our college there is a course on mind body medicine. It's really sounds very different, because this course mainly deals with how you can regulate the secretion of hormones based on your response to your lifestyle, your environmental factors and other things. Because if you don't have enough sleep, your cortisol is higher. Okay, the cortisol is one of the hormone which can increases the glucagon level. Glucagon, you know, is one of the hyperglycemic hormone. Okay, that is, it increases the glucose level. So if you don't sleep and if you often get tensed, this cortisol develops, secretes quite often. The cortisol, which secretes often in your body, will release excess glucose, and your blood glucose level is high, which in turn, of course, affects your metabolism in many aspects. I don't know whether you have biochemistry as paper, but if you look into if you know that the metabolism, the tricarboxylic acid cycle, you can see all, because this is the cycle which is connected to all the other metabolism. So the increase in glucose level is the one parameter which will spoil all the other metabolism. So please take care of your emotions. Please take care of your sleep. I would say, because these are all very, very important. If you have a habit of doing yoga, I would encourage, because control your hormonal secretion. Then?
Yes, ma'am. Thank you. And we have another question.
Yeah.
Cancer comes to a person if their parents have.
Yeah, that's what I told you, no? It depends. So, because suppose if one parent has got this cancer, probably the mother has a cervical or a breast cancer, or the father has some kind of cancer like prostate cancer or colon cancer or throat cancer. There are a lot of cancers are there. So it's you need to go for genetic counseling. The genetic counseling will give you an idea. They will go for a pedigree analysis. The pedigree analysis will give you the generation after generation picture, F1, F2, F3 generation, and also they will see the probabilities of you getting the chance of getting that particular cancer. So if at all you have just such kind of doubt, please don't delay. Kindly go to your doctor, take the advice and do the genetic counseling, do all these analysis, do the karyotyping you can do. Karyotyping is a test where they do check your chromosomal distribution. From that, you will understand if there is any kind of chromosomal aberrations that will reveal that you have, you may get a chance of getting this. So you can go for such kind of karyotyping and cancer marker testing, and the chance is based on the pedigree analysis. So that you can do and find out.
Yes, ma'am. Thank you. One more question has been asked. Like my mother had a non-Hodgkin
Sure, sir.
lymphoma. Now she is fine after treatment. So what are the precautions that I have to take? So is it hereditary? This is what the question.
She has a what is that? What
My
leukemia?
mother had non-Hodgkin lymphoma.
Lymphomia. Okay.
Lymphoma. Now she is fine after treatment. So what are the precautions that I have to take? So is it hereditary or not?
So how many? I would like to know, if possible, that student can type the answer. So how many siblings you have? So based on the number of siblings, you need to do this analysis, and also you can do once in 6 months the peripheral smear. You give the peripheral smear test, and this is the basic test that the doctors do to find out the changes in the morphology of the blood cells. So this is one of the very basic tests, and of course they can find out, and just look for your menstrual bleeding and the changes in the color of the skin, and if there is any changes in the color of the skin and changes in the size of the mole that you have. So all these you can note, and you can do some of the test of the leukemic cancer test markers. So that you can do, and you can clear your doubts. So you need not worry when I say it is genetic, it all the probabilities. So you may or you may not get, or this generation will not be getting any kind of symptoms or any cancer. Probably the next generation. So there is always the hereditary information passed on like that. If not the immediate generation, probably the next generation. So this analysis, pedigree analysis, will give all kind of information on this. So genetics has got a very good role in giving the probabilities of getting the cancer. So, and I would like to tell, there is a big provision is available in our hospital. We have a genetic, because you have a lot of concern over the hereditary background. I would like to share this with you all. We have a human genetics department which is attached. They have a very beautiful diagnostic laboratory where we do all kind of the karyotyping and the analysis and cancer test markers and chromosomal aberration aberrations through karyotyping and fish fluorescence techniques available. So suppose if you are doubt of getting all these tests to be done, where to go, what to do, please come to us or come to me, call me. I will do all the needful. And what you can do, that is, you can do that at the earliest. That is what is very important. Okay, we have that provision. Yeah.
Yes, ma'am. Thank you. And we have another question.
Yes.
How photoacoustics agent can be useful in prostate cancer?
In what cancer?
Prostate cancer, madam.
Prostate.
Prostate cancer.
Photoaquatics.
Photoacoustic agents. How photoacoustic agents can be useful in prostate cancer?
But I'm not very sure about that.
Okay. So the same person have asked another question. So is there any signs and symptoms that are the cancer has spread beyond the prostate cancer? Hello, ma'am. Am I audible?
Yes, sir.
There's another question from the same student. So is there any signs and symptoms that the cancer has spread beyond the prostate?
Yes, because this in terms of analyzing themselves or through the markers analysis. See, of course, the prostate cancer has a metastatic role because, as I told you in the beginning, it can spread to the bone and lymph nodes. That is actually advanced stage. Okay, so you will have you cannot able to walk because your bone symptoms that a person who is having advanced cancer, and I think it's in the 4th stage, so that your bone will become very, very weak, and the other 2 symptoms will be there: vomiting with the blood and bleeding in the urine.
Okay, ma'am. Aishwarya, is your question is answered, or if you want to talk with ma'am, you can raise your hand. I can allow you to talk. So if you have, suppose you want to ask some more questions to madam, I can allow you to talk. Okay. Ma'am, I have another question. For treatment of this cancer, which process is better, IGRT or SBRT?
See, normally they start with IGRT, and then if it is not successful, then they will go for that next one, GRT.
Ma'am, I have another question.
Yeah.
Cancer condition worsens if the patient is affected with COVID. Are they related?
Because yes, of course, because cancer is one such compromised, right? Where your immune system is manipulated. All your CD4 and CD8 cells, they are manipulated according to the need of the cancer cells. So they are immunocompromised. So definitely, if the cancer, that is why we had a separate awareness program for cancer patients as well as the tuberculosis patients during this time, that how to be aware of being away from the COVID, as well as taking what kind of food, and all those measures were given as an awareness program to these patients. So at this immunocompromised state, the patients have to be very, very careful, because once they get this COVID, definitely it is difficult. So of course they are prone to.
Okay, ma'am. So thank you for your answers for all the questions.
Yeah.
And ma'am, I have one question.
Please.
So is this prostate cancer affects the secretion of testosterone hormone, thereby reducing the semen count? So is there any relation between that?
Is there thereby reducing the
semen count? So is there any relation
yes,
between?
Of course. Yes, because it affects, and the people will have, because the semen they have erectile dysfunction as well. They develop erectile dysfunction. So because of that, the synthesis of the volume of semen and the count is also decreased. So maybe probably in the beginning there won't be any such problem, but once the treatment after this ablation therapy, this androgen deprivation therapy, of course they do have such kind of problems which where the count is less, and so they may develop the impotency.
Okay, so ma'am, can you just tell me what is a common screening test that can be carried out for prostate cancer?
Hello.
Ma'am, am I audible? Hello. Am I audible?
Yeah, yes sir.
Ma'am, could you just tell me about a common screening test that is carried out for prostate cancer?
The basic test, yes. The basic test is measurement of PSA, and then PSA, the prostate antigen, serum antigen. So the PSA is the basic test that you could do, and then you can go for some biopsy. So this biopsy will give you the morphological changes, and the PSA, and then they go for the entire prostate CT scan.
Okay.
So with that, so it is all not at the same time. Based on your PSA level, they will give you further test to be done.
Okay. Can you just tell me what are all the preventive measures that could be taken through food factor? That is, what all the diets can be followed?
Please avoid lipid containing food. Avoid in the sense minimize.
Okay.
Because after the age of 40 itself, it's better to avoid all such kind of lipid containing food and regular exercise. Because as I told you, the lymphatic system is one such system which will remove the unnecessary toxic substances, which includes carcinogen as well. So the regular, having lipid free or lipid less food and exercise may be the good preventive measure for any kind of cancer. Because this cholesterol metabolism is a major pathway involved in progression or pathogenesis of prostate cancer, I would request all the men to have a less lipid containing food and good sleep and regular exercise.
Thank you, ma'am. Thank you so much for your answers for all the questions.
Thank
So is there any other questions from the participant side?
Prabha, I have one
yes,
question.
sir. Please, sir.
Ma'am, like the symptoms of kidney failure and this prostatic cancer are almost similar, right?
Yeah.
But how can we distinguish between these two?
That is why, sir, most of the time we miss out, because we never think when we have all these kind of symptoms, we thought that, yeah, I have the UTI. So I go and take antibiotics or do the culture. So when we do the culture, of course, the UTI will have some kind of microbes, and we take some antibiotics. For that time being, you will be relieved. But we don't think about measuring the markers of PSA or any other. And presence of 0 to 5 cells, blood cells in the urine is not significant. So we don't take it into consideration. But what I would say, based on the discussion, if you have a repeated problem of these kind, then we must go to a doctor and ask for, tell the frequency of the UTI that you face often. And then it's better go for the PSA and the scan test, even the biopsy.
Okay, ma'am. Thank you.
Yes.
And it was actually a wonderful talk, ma'am. It was probably eye opener for us, and it's. I think you've given just an outline, but it was so good and interesting. It was wonderful talk.
Yeah, see, because I didn't take the research paper, but I just wanted to give a broad view of about the prostate cancer, because many of us, we don't take it very seriously, sir, this one.
Yes, ma'am.
So, yeah.
So, and I really appreciate your patience. Almost like it has been like 30 minutes you're answering.
No, so it's pleasure, sir, answering the students' question.
Okay. Prabha, anything else? Any other questions we can, or we can close the session, if anything?
Yes, sir. I guess all the questions have been answered by Madam. Whatever questions in the chat box we have discussed. So is there anything other questions that has to be discussed from the participant side? You can put it in chat box, or you can raise your hand. We will allow you to talk. So if all the questions are answered, if no more questions is there, I think we can wind up, Madam.
Yeah. Thank you so much, sir, for this opportunity. And I would really appreciate the students for their questions, because I thought there won't be any much questions, but it was really very interactive. I appreciate all the students. to learn that they need to have a healthy life. Everything comes next. Okay, so kindly have a good healthy life, wherein please follow two things very strictly. One is three things actually. The first one I would say, go to bed on time. The second one, eat healthy food. And the third one, do regular exercise. Whether you are young or old doesn't matter. So you need to love your body by doing regular exercise and keep yourself healthy. Okay, thanks a lot.
Madam, yes, ma'am, we can formally.
Yes, sir. Thanks a lot, sir. Thank you.
Thank you very much,
Santoshini,
ma'am.
ma'am.
It's actually really a nice talk, and thank you very much for accepting it when I asked you.
Sir, we'll
Thank you.
formally do it, sir.
Yeah, we'll formally.
Santoshini, ma'am, please formally wind up, madam.
Yeah, sure.
Yes, sir. Yes, sir. As an end comment, I would like to sincerely thank our management for permitting us to conduct this webinar. And I would like to thank our today's speaker, Dr. A. Sumati, for sharing the valuable insights about cellular growth factors on therapeutic targets for combination therapy in androgen independent prostate cancer. And I would like to thank our HOD for his support extended towards this webinar session. And I would like to thank our fellow faculty members for their wonderful coordination. And finally, I would like to wholeheartedly thank all the participants from different locations for your presence and making this webinar a success. Once again, thank you all. Thank you, ma'am. Thank you.
Thank you.
Thank you so much, ma'am.
Thank you, sir. Shall I leave?
Yes,
Yes, ma'am, I think we
Thank
can.
you. Thank you.
Thank you.
Yes, ma'am, thank you.